Visible.
Starting with my case, my patient, Mr. ABC, is a 35-year-old male, Hindu by religion, tailor by occupation, a right-handed individual, hailing from Ville-Parle, Mumbai, came with the chief complaints of weakness in both the lower limbs since 15 days, decreased sensation in both the lower limbs and lower trunk below the umbilicus since 15 days, and difficulty in passing urine before 15 days. The patient was apparently all right 15 days ago when he started developing weakness, which was acute in onset, affecting both the lower limbs, such that he had difficulty in using the pedal of his sewing machine. While leaving from work after 4 hours, he tried getting up from his seat, but he fell down. The patient could not get up even on getting help. There was no history of weakness in upper limb or face. He also developed a feeling of numbness in both his feet, which progressed in 6 hours to involve the entire lower limb and lower half of trunk. The numbness was also associated with a pain in the back at the level of umbilicus, as if a tight belt was worn. On further inquiry, the patient also gave history of inability to pass urine, which led to retention of urine and distension of abdomen below the umbilicus, and was catheterized for the same as soon as he was brought to hospital by relatives on the same day of the symptoms. As told by wife, after insertion of catheter, almost 1000 ml of urine was drained in the urine bag. Patient also had history of fever with loose stools 3 weeks before the onset of symptoms, which was treated with medications at a local hospital. There is no history of altered sensorium or loss of consciousness or convulsions. There is no history of decreased sense of smell, loss of vision, double vision, squint, asymmetry of face, inability to close eyes, diminution of taste sensation, loss of hearing, tinnitus, vertigo, difficulty swallowing, nasal regurgitation, nasal twang of voice, difficulty in shrugging shoulders or turning neck to one side, deviation of tongue or on protrusion. There is no history of evening rise of fever, cough, expectoration, weight loss, bone pain, COX or any COX contact. There is no history of trauma or any injury. No history of dog bite or recent vaccination. No history of recent drug intake intrathecally. No history of radiation to the back. No history of chronic radicular back pain. No history suggestive of Lermit's phenomenon or the Barber chair sign. No history of arthralgia, photosensitivity or rash. No history of thyroid illness. No history of high-risk behavior. There is no history of fever with chills and rigors or cloudy urine or hematuria. No history of unilateral or bilateral swelling of lower limbs. No history of acute onset of breathlessness. No history of bed sores. The patient was admitted 15 days ago and was started on IV medications. A urinary catheter was inserted, after which his bladder symptoms were relieved. The motor and sensory symptoms have not improved much. He is currently on physiotherapy treatment. The patient has had no history of any similar episodes in the past. There is no history of hypertension or diabetes. No other significant medical or surgical history. There is no history of smoking, alcohol, or any drug addictions. No history of allergy or atopy. No history of sleep disturbances. The appetite is normal. The patient is a non-vegetarian and consumes mixed diet. The family history is non-contributory. Coming to the summary, Mr. ABC, a 35-year-old male, presented with acute onset weakness and numbness of bilateral lower limbs since 15 days, which started distally and progressed proximally. The patient also had a band-like sensation at the level of umbilicus. History of urinary retention is present. The past history is significant for loose stools 3 weeks ago. Ma'am, should I proceed or we'll discuss this?
We will discuss the history.
Yes, ma'am.
But of course, this case may be very simple, but still we will see loose stools. No? What are the situations where loose stools give important clue to the neurological illness? That is the first thing we should try to analyze. So I am sure you know that. You want to tell some answers, you can tell. Otherwise, I will discuss. Whatever you feel like is comfortable, we can do. So loose stool is a heralding event, no?
Yes, ma'am.
So what are the things going through your mind when somebody says that they had some GIT symptoms?
Ma'am, the first thing that comes to mind is Campylobacter infection, which later has led to Guillain-Barre syndrome.
Very good. So that is.
But here urinary retention is present, so Guillain-Barre syndrome is lower down in the person.
So just we will discuss that thing. So you want to think of Campylobacter infection, which commonly leads to AIDP. In what way would you like to tell what does Campylobacter or any infection for that matter can do so that this kind of complications happen?
Ma'am, there are antibodies, autoantibodies start forming against the myelin protein, and then these antibodies affect the myelin in the spinal cord and the nerve roots and nerves. So it is a myeloradiculopathy basically.
So wonderful. So what can happen is these infections can have, these agents can have antigens which are shared with the host cells. So when our body reacts and tries to eliminate the infection by creating antibody against the organism, they can cross-react with the self-antigens also. That is called biological mimicry. So the antigens present in the organism may be, some of the antigenic part of the organism may be shared by the human structures. So that can produce cross-reacting antibody. The antibody production in nature is to eliminate the infection, and along with eliminating the infection, it can attack the host cells also by misunderstanding that the host cell is the organism. So that is one thing that phenomena is called molecular mimicry and biological misidentity, because of the mimicry by the antigenic sharedness of some antigens of living organisms. This can result in biological misidentity. So these antibody attack the host cells. That is one thing. Second aspect, these antigens there is something called Burnet's clonal selection theory. You are MBBS student, you will be actively reading all these genetics and microbiology, all those things. That's called Burnet's clonal selection theory. Some of the infections, apart from infecting the target organ in which it is working, it may also destroy some other host cells, so exposing it into self-attack. So that happens in certain specific organs. That is thymus, thyroid, lens, testes. No, this is called by a phenomena called Burnet's clonal selection theory. I'm sure you would have just read it recently in your previous fourth year. You might have read. So, according to Burnet's clonal selection theory, you gave very good answer regarding Campylobacter. So, clonal selection theory is normally there are multiple self clones which are immunologically charged, and these clones will be informed. Each body part is supposed to go and inform to these self clones, that is blood groups, everything. So the body knows this one belongs to me. So sometimes some capsulated organs like thyroid, thymus, testes, lens, they may not go and introduce themselves to the self clones. Because of that, once some injury occurs due to any infection, trauma, surgery, any situation, these things are not identified as self. So they are identified as non-self and results in attacks. So that is Burnet's clonal selection theory. Some organs are not introduced. You might have heard about same person having two different blood groups in different times. We call it as chimerism. That's also because same phenomena. Some dead binovular twin may be there, or some cross reaction of maternal blood with the fetal blood might be there, but that is not introduced to the self-clone. So it is two different types of blood groups can circulate in the same person. In the same way, because it is not identified as non-self. Similarly, these organisms which are not introduced to the clones do not know them as self. So when any insult happens to these organs due to infection or any situation, antibodies will be produced thinking that they are non-self. So these are the two mechanisms, molecular mimicry and biological misidentity, or cells which have not been introduced to the self clones. So they are identified, they are destroyed in the infective process or trauma or whatever, resulting in antibodies being produced by the human against these cells. So that is the basic mechanism of autoimmunity. So you said that it could be a Guillain-Barre syndrome, LM and paralysis. Very much possible that it's a weakness of both legs. We'll come to it later. Other situations where abdominal pain can precede, you should know polio. You see?
Yes, ma'am.
Common. It is eradicated. It is eradicated, but still you should remember, because it is eradicated, it might affect senior, older people. When it is virgin population, which is not exposed to polio, it can, when it comes back, it will affect older people. Otherwise, older people are vaccinated or they have developed infection-induced immunity, so the children gets attacked. When a disease is eradicated and it comes back, it usually attacks older people because they are as unprotected as the children. So it can be polio or polio-like illnesses. You have got polio viruses and you have got polio-like ecoviruses, cytomegalovirus. They can produce polio-like illness preceded by GI. Ecoviruses specifically produce enteric symptoms. So it could be that. So whether it is a gastrointestinal infection followed by Campylobacter and Guillain-Barre syndrome, or is it a polio and polio-like illness? And then you have got other conditions which present with the abdominal symptoms and the neurological deficit. For example, there is a condition called Mecentric Angina. This is supposing you have a vasculitic process. Whenever you take food, the intestine goes into activity. It is like cardiac angina. When the intestine goes into activity, mecentric angina will come. So when you take food, after some time, patient will develop bloody diarrhea because of the mecentric vasculitis. And the same vasculitic process can involve the peripheral nerve, spinal cord, brain, any part, and produce neurological disease. So is it a Campylobacter followed by Guillain-Barre, or is it a polio-like illness, or can it be a
transverse myelitis,
angina and vasculitis? Then I am sure you know that you have got conditions like porphyria.
Yes.
Porphyria, then paraneoplastic syndromes like hypercalcemia, which produces abdominal pain. Paraneoplastic hypercalcemia will produce abdominal pain. Porphyria will produce abdominal symptoms. And then you have got mitochondrial disorders. It may be too much for you, I do not know. Because you very well, I'm sure you will be interested. So Mingi, it is a gastrointestinal, it presents as diarrhea only. Mingi is a mitochondrial disease, not the classical MELAS or the MRF. This Mingi syndrome is there. That is typically presenting with gastrointestinal symptoms. Child will get repeated diarrhea, and you investigate for all kinds of organisms, and later they go into paralysis, encephalopathy, and they die. Very, very difficult to treat condition. Some mitochondrial diarrhea, Mingi, M-I-N-G-I, Mingi syndrome. Then you have got celiac disease, gluten sensitivity, celiac diseases. Then you have got cerebrotendinous xanthomatosis. They all produce GIT symptoms. So GIT symptom can be infective followed by para-infectious conditions, or infection and primary infection affecting the neuraxis like polio-like illnesses, or it could be vasculitis due to mecentric angina and peripheral nerve vasculitis, or it could be porphyria which can produce abdominal pain, loose stools, and later it can produce neurology, or paraneoplastic syndromes where hypercalcemia and paraneoplastic other kinds of complications, or it could be cerebrotendinous xanthomatosis, or specific gastrointestinal mitochondrial disease, Minghi, or celiac disease. All these conditions are neurologically relevant. So GIT symptoms which are neurologically relevant comes under this. Under this category, yes, you clearly pointed out, commonly we see Guillain-Barre syndrome. Less commonly you may see polio. Then little more less common, you might find spinal cord involvement, or you might find cerebral involvement. So these are the causes for a person developing an acute weakness of both lower limbs. So you classically told Guillain-Barre. Next we considered polio. Then we are considering spinal cord involvement. And then we are considering cerebral paraplegias due to CNS vasculitic process involving the CNS. Unlike the embolic strokes which involve the MCA territory, vasculitic processes involve other vasculature, not the classical MCA. So ACA can be involved.
Unpaired ACA, yes, ma'am.
You can develop cerebral paraplegia. So these are the quickly my mental process which you will go through. So you are undergraduate students. So we will first discuss. Forget about this class. We will come to it later. Just to try to differentiate. How are you going to differentiate an acute flaccid paralysis from Guillain-Barre syndrome, polio, and spinal cord involvement with shock? Cerebral paraplegia will not come under this. So here first polio, as you know. Now we can say child is not a disease of children. It will have a completely virgin population. So older people can affect. So age is not a thing which is going to help you. So second point, pain. So pain in the limbs is seen in polio. It is also seen in Guillain-Barre syndrome. And flaccid paralysis is seen in polio, seen in Guillain-Barre syndrome. So these are the common things why you will consider it as a differential diagnosis. Now, what are the points which help you to differentiate? One is polio is a meningitis. It's a viral meningitis. Whereas Guillain-Barre syndrome is an immunological syndrome. Because of that, if you find some neck stiffness, it is going to be helpful because respiratory involvement, cranial nerve involvement, all are shared with every other condition. So if you find a neck stiffness, then you know that it is going to be polio. And if there is no, a patient not having neck stiffness, is not going to help you. But if neck stiffness or Kernick sign, you are able to demonstrate even briefly, that is a point in favor of polio. It never happens in Guillain-Barre syndrome. Second pattern, he is an adult. So you can look for numbness. So numbness never happens in polio, but the mild sensory involvement happens in Guillain-Barre syndrome. So presence of sensory features, subjective as well as objective, is favoring Guillain-Barre, but it is never seen in polio. Third point, pattern of involvement. So you have gotten radiculoneuropathy. Guillain-Barre syndrome is otherwise called as acute inflammatory radiculoneuropathy. So it will be the radicals. As you know, the proximal weakness is more. I am sure you might have seen Guillain-Barre syndromes. Unlike the classical peripheral neuropathy, which is length dependent and involves the distalmost part, Guillain-Barre syndromes are proximal is more weak than distal. Why? It is a radiculoneuropathy, and the radicals have more myelin. It's demyelinating, as you typically told. Radicals have more myelin. When you come down, as you reach the peripheral, the myelin is less. So it will affect the part which is having maximum myelin. That is why it also does not affect the pain and temperature fibers. It will affect the motor fibers. It will affect the proprioceptive fibers. It will affect the proximal fibers. So short axons have more myelin. Motor fibers have more myelin. Proprioceptive fibers have more myelin. So radiculoneuropathies affect the more myelinated fibers. So it is more proximal and more motor and more proprioceptive. Whereas polio, so did you understand any doubt? You are a small child. So if you have any doubt, you just feel free to ask me. I am sure you are following. You classically told it's a post-infectious demyelination. So demyelination means it will attack the fibers which are having myelin. And maximum myelin is there in the short axons than the long axon. That is why Guillain-Barre is not length dependent. Guillain-Barre is not length dependent, it is myelin dependent. So it will produce weakness more proximal than distal. Second, I am sure if you have seen even one Guillain-Barre, you will know that pinprick and temperature will be better appreciated than vibration. Because proprioceptive fibers and motor fibers are more myelin than pain and temperature fibers. Because of that reason, they will have less involvement of pain and temperature, but motor and the proprioceptive will be more involved. That is the pattern in Guillain-Barre. Whereas if you take polio, it is a disease of the anterior horn cell and the meninges. Because meninges is involved, there is a neck stiffness. Because anterior horn cell is involved, there is a unique pattern called column pattern. Acute flaccid paralysis will be a question for undergraduates, postgraduates, super specialty people, everybody. So it is good to know. That is called column pattern. Because it is not a radiculopathy, it is not a demyelination, it is an anterior horn cell disease. So what is that column pattern? You are just fresh from anatomy, I am sure you know that. Muscles are either short column muscles or long column muscles. What we mean by that, supposing you take, I'm sure all of you are used to, what is the jerk value of knee jerk? We'll say L2, 3, 4, no?
Yes, ma'am.
Like that. That's a long column muscle. So quadriceps is a long column muscle. It is getting supply from several roots, even though the primary root is L3, it gets fibers from L2, L3, L4. So it's a long column muscle. So many segments in the spinal cord are contributing the nerve roots which innervate the quadriceps. But supposing you take interosseous or short muscles, it has got only S2. If what is the root value of S2, you will not say L3, L4, L5, S1, you will not tell like that. You will say it is S2. So it is getting innervation from short columns, few segments. So they are called short column muscles. Because polio is an anterior horn cell disease, if it involves the long column muscles, the paralysis will be less. Suppose, unlike Guillain-Barre, where the proximal muscles, so quadriceps will be weak. Whereas polio, if the polio affects the nerves that supply the quadriceps, it will be only minimally weak. Why? Because it is having so many segments. So long column muscles are less seriously affected. But if short column muscles are affected, they will have grade 0 power. Because it is an anterior horn cell disease. One anterior horn cell is knocked out. Short muscles do not have any other anterior horn cell. But if you have quadriceps, it is having so many anterior horn cells. L2 will give, L3 will give, L4 will give. If one is gone, others will support it. So this polio pattern is called column pattern. What is that column pattern? The muscles which have short columns, that is muscles which receive their innervation from very few anterior horn cells. If they are affected, they will be severely affected. If the muscles that get anterior horn cell from long column muscles, if they are affected, they will be minimally affected. So it is the reverse of what you get in Guillain-Barre. Understood?
Yes, ma'am.
So it's a column pattern. Polio has a column pattern. Guillain-Barre has a radiculoneuropathy pattern. So that is the next point that helps you. And then of course, so 3 clinical points: sensation, neck stiffness, pattern. Then if you go to the laboratory, you find a cellular CSF, whereas cytoalbuminuric reversal is Guillain-Barre.
Yes, ma'am.
So CSF will be cellular in polio because of the viral meningitis. Whereas in Guillain-Barre syndrome, you'll get cytoalbuminuric reversal, where the cells are very, very less or not there, and protein is increased. Then, of course, you do the electrophysiological studies. You will find that nerve conduction will show typical pattern of abnormal conduction, which I will not go into. You're a small girl. So abnormal conduction will be seen in Guillain-Barre, whereas polio conduction velocity will be normal, because the roots and the nerves are not affected. It is only the anterior concept. Whereas electromyography, which shows the EMG pattern, the EMG will be abnormal in both Guillain-Barre and polio. But nerve conduction will be normal in polio and it is abnormal in Guillain-Barre. Next point, if the person comes a little later, he would have either started improving on his own, whereas polio improvement takes very long time. And areflexia is seen in both conditions. So if it is a Campylobacter or whatever the GIT infection which led to polio or Guillain-Barre, these are the points by which we will differentiate at the bedside. Next is a spinal cord disease with a shock. So any GIT infection can produce molecular mimicry, biological misidentity at the spinal cord cell level, and it produces an acute myelitis. Then how are you going to consider it as a flaccid paralysis? If it is in shock, there is something called spinal shock. I'm sure you might have heard spinal shock. When there is an acute myelitis, patient will not be having hypertonia of upper motor neuron disease. Instead, patient will show hypotonia. So that is called shock. So spinal shock is, I'm sure you might have heard this word. You will be reading it in your final year only, I know. Yes, undergraduate students will know spinal shock definitely, but you will be into that process now. So what is spinal shock is, in human beings, spinal cord is a conducting pathway. It is not ordering anything. Unlike animals, in lower animals, lot of reflex activities are being done independently by the spinal cord. Brain itself is not that big. But in human beings, it is only a transmitting station. It is not having much independent activity when the brain is okay. Supposing yes, acute transverse myelitis happens and the spinal cord is suddenly into tragedy. Supposing somebody is telling, tomorrow you become the prime minister of the country. You are not used to that job at all, but you are forced to do that. So there will be few days when you are totally inactive. You don't know what to do, where to start, where to end. That is that called shock. So when there is a sudden disconnection of cerebral communication to the spinal cord, and spinal cord is told to independently carry out the activity. Due to sudden loss of bombardment of cerebral commands to spinal cord, in an acute myelitis, patient goes into a phase of shock. So he doesn't know, spinal cord doesn't know how am I going to move this person. So shock is having three phases. One is the phase of atony. Atony is the time taken by the spinal cord to realize how am I going to carry out my activity without getting orders from the brain. So that is phase of atony. And after that, depending on the degree of damage, the undamaged part will become overactive. That is called phase of hyperactivity. And third phase is phase of recovery. So if it is a spinal shock also, patient will be in flaccid paralysis only. So not only polio and Guillain-Barre, it will be flaccid. And it has three phases, phase of atony, phase of heightened activity, and phase of recovery. What is that atony? It is due to sudden loss of bombardment of cerebral commands for activity in the spinal cord. So at that point, patient will be atonic, areflexic, plantars will not show any upgoing, and he will have paralytic ileus because of the bowel atony, and he will have incontinence because both the body of the bladder as well as the sphincters are atonic. During shock, urine will not be stored. Only when you are into recovery, the urine will store. So that is the second phase. So in the phase of spinal shock, acute stage, there is complete atonia, complete areflexia, there is total loss of sensation, total loss of power, paralytic ileus, and incontinence. This will be followed sooner or later based on the degree of injury and insult to heightened activity. What are those heightened activity? Thermoregulatory function is there. You know, the intermedial lateral brake column, the sympathetic in the thoracolumn or region. So all this thermoregulation will fail below the level of lesion. Because of that, patient will have thermoregulatory sweating above the lesion, because the lower part is not doing thermoregulatory function. There will be exaggerated sweating. So patient will sweat a lot. Then he will have mass reflex, spontaneous spasms, and he will start emptying urine and motion involuntarily, and he may have exaggerated reflexes. And so that is the heightened activity phase. After this, it will settle down to recover the parts of the neuraxis which are not really damaged. So usually in a classical case, the sensations and the power starts recovering first. So usually uncomplicated case, by 24 to 48 hours, if the patient has total loss of sensation and total loss of power, it is not due to shock. It indicates the complete spinal cord injury. So if it is due to shock and the spinal cord injury is only partial, the first thing to recover is sensation and motor. So by 24 to 48 hours, if the person does not show any sign of improvement in sensation and power, that means it is a severe myelitis, and the atonia or the loss of sensation and loss of power is not due to shock but due to the disease itself. So that is the phase of recovery. Power and the sensation recovers first, depending on the unaffected tracts. Second thing to recover is the flexors recover earlier than the extensors. That is why patient develops flexor spasms. Then the third thing to recover is the sphincters recover earlier than the body. So they go into constipation and retention of urine. The knee jerk recovers earlier than the ankle jerk. So this usually completes within 1 to 3 weeks, depending on the other parameters which may prolong the shock. Like if the person has severe sepsis, the shock will be prolonged. And if the lesion is very far away from the brain, the shock will be prolonged. And it will be human beings, the shock is more than animals, because animals have some independent spinal functions. So if these are the three flaccid paralysis you will consider. One is the Guillain-Barre, second is the polio and polio-like illness, and spinal cord lesion with shock. Then other causes for paraplegia, we thought we should consider cerebral paraplegia also, which is less likely in this context, but still we will analyze that. So at this point, I will want you to learn the second thing. So diarrhea followed by flaccid paralysis, differential diagnosis, Guillain-Barre, acute flaccid paralysis, and spinal cord involvement with shock. Then next thing, how are you going to differentiate an upper motor neuron? Because we have considered myelitis, which is upper motor neuron, and Guillain-Barre, which is element. So just because you are an undergraduate girl, I'm sure you are very well informed in neurology. Still, I will revise it for the students who might need it, or the smaller boys and girls. No? How to differentiate an UMN paralysis from an LMN paralysis after the period of shock is over. UMN, there will be hypertonia, whereas LMN, there is hypotonia. Second point, UMN, there is movement loss. I will tell what it is. Movement paralysis, whereas in LMN, it is the muscle paralysis. What I mean by that, suppose movement paralysis is one type of movement is paralyzed in an upper motor neuron disease. Patient cannot walk. He cannot voluntarily flex his legs. But if you do the knee jerk, you find that the knee reflex is exaggerated. That means voluntary movements are paralyzed reflex movements are exaggerated. That is upper motor neuron. Because reflex functions come into play as voluntary movements cannot be carried out. The voluntary command is disconnected from the hemisphere. So upper motor neuron, one kind of movement only is getting paralyzed. So other kinds of movements can be elicited. It happens in hemiplegia, paraplegia, everywhere. So by the reflex, you can demonstrate exaggerated movement. Voluntarily movements are not there. Whereas in LMN, it is the end organ. It is like the bulb that is damaged. So whether you correct the main switch or you do not correct the main switch, as long as the bulb is damaged, the light will not come. So LMN is muscle paralysis, either at the level of the muscle or at the level of the root or at the level of the nerve or anterior horn cell. LMN is muscle paralysis. So there is all kinds of movements are paralyzed, both voluntary movements and the reflex movements. Upper motor neuron movement paralysis for a class of movements. So voluntary movements are not there, reflex movements are exaggerated. Whereas in LMN, both voluntary and reflex movements are lost. Third point, superficial reflexes are lost and deep reflexes are exaggerated in upper motor neuron. Whereas in lower motor neuron, both superficial and deep reflexes will be lost. Then upgoing plantar is seen in UMN, whereas LMN, there is no upgoing plantar. And over a period of time, rapid wasting takes place in LMN. Whereas in UMN, over a longer period, you can get disuse atrophy. You don't get that much wasting in UMN disorders. Then as you typically you were trying to tell, involvement of the bladder. Can Guillain-Barre produce bladder? Sometimes, not always.
Atypical.
Yes, it can produce a motor denervated bladder, severely painful retention. Because as you know, even though bladder is having a parasympathetic control, there is also a voluntary control. The abdominal muscles are also needed to empty the bladder completely. So in a Guillain-Barre syndrome, if the abdominal muscles are all flabby and atonic, during that phase, due to loss of that component of the voluntary muscles, patient will have painful retention, but it is very brief and it will become all right. Whereas in spinal cord, the type of bladder will be different. That will come to later. So, and sensory loss will be cord pattern. Whereas in Guillain-Barre, there will be proprioception. Whereas in polio, there is no sensation at all. So, sensory loss at all. So, how to differentiate UMN from LMN? I think it is clear. I am sure you know this, but I just summarize for younger children who may be there in this session. So that is the paralysis. Then how are you going to think of a cerebral paraplegia? Supposing this person had a mecentric vasculitis and he had an unpaired anterior cerebral artery which got occluded and the leg area is supplied by the anterior cerebral artery. So he gets a cerebral paraplegia. Very occasionally these things happen and we have seen, but you may see one case or two cases in your lifetime. You may investigate the spinal cord or peripheral node, you don't find anything, you are surprised what is happening. Is it psychogenic? All those things you will think. Because of frontal lobe involvement, patient can have some behavioral issues also. So you will think it is a psychogenic paralysis. You may think because you investigate extensively some other site, because it's a very less common condition. So what happens in cerebral paraplegia? One, you have weakness and you have sensory loss, but the sensory loss will be for cortical sensation. Because behind the motor cortex, you have got the sensory cortex, which observes cortical sensation. Whereas vibration, joints, pain, temperature, all those things will be normal. Cortical sensation will be impaired. Second, it can mimic a peripheral nerve by patient's symptom. So you should be careful. Why? Because if you take the homunculus, human homunculus, the motor cortex and the sensory cortex, the motor homunculus, patient's leg from the hip is in the interhemispheric fissure. Whereas sensory homunculus, it is below the angle. So something happens to the medial frontal region due to unpaired anterior artery getting occluded. The sensation will be much less. It will not be from the hip. So that also you should know. So you should not think, so it looks like a peripheral nerve. Why is the sensation distal, whereas motor is proximal? That is exactly cerebral paraplegia. So, because of the homunculus. Sensory homunculus angle, up to angle is only in the interhemispheric fissure. Whereas motor homunculus, from the hip it is in the interhemispheric fissure. So that way it will imitate. So you should carefully see, and you will see that it is the cortical sensation. Second thing, you see look at the bladder. The bladder will be of frontal uninhibited bladder.
Yes, ma'am. Infant-like bladder.
So he will simply pass urine whenever he wants. It is not that he is unable to store, unable to initiate. He can initiate, he can store, but he is unconcerned. Next point, in a spinal cord, you may get clonus, but in a cerebral paraplegia, an equivalent of the clonus will be seizures because it is cortex, it is motor cortex. So patient may have rhythmic repetitive seizures involved in the legs. So clonus comes only when the leg is stretched, whereas seizures come spontaneously. Even when there is no stretch, it comes rhythmic, repetitively comes and stops on its own. So seizures, presence of seizures is cerebral paraplegia. Then associated behavioral problems due to frontal lobe involvement. So these are the points. So there is a motor weakness, more than sensory. Sensory will be cortical sensation, bladder will be cortical uninhibited bladder, and you can have seizures, and you can have behavioral issues because of the frontal lobe involvement. So this is how, these are the things which should go through your mind when somebody comes with acute paraplegia. Of course, you have got psychogenic paraplegias, where patient may say total loss of sensation, but generally they are not incontinent. They don't have the phase of shock or heightened activity. They may just refuse to walk, and voluntary reflex dissociation, nothing will be there, no signs will be there. And you have got the test which we can do if the patient is claiming a partial paraplegia, not a complete paraplegia. There are tests which can help you to differentiate that it is psychogenic, that we will go to later. So these are the possibilities: gastrointestinal infection followed by weakness. Are they related or are they unrelated? If they are, and what are all the causes for weakness? We have gone through. So we are keeping on these things in our mind. Our patient is having, as you said, he is having weakness with a definite sensory level in the trunk. So yes, if it's not a Guillain-Barre pattern, so Guillain-Barre sensory will be distal, cerebral paraplegia will be distal, polio will be no sensory. So this has to be in the spinal cord because patient has got a sensory level in the trunk. Second important point you told me, that is having a tight band-like sensation.
Yes, ma'am.
What is the tight band?
Ma'am, it is usually seen in lesions involving the posterior column or the crossing of the spinothalamic tracts, or in the nerve roots sometimes. Very good.
So trunk sensory impairment, three things you will consider, whether it is a root. You are very good. You become neurologist. No, wonderful. No? It is because you see, neurology laboratory will not always give you the answers. You have to correlate laboratory with clinical findings. Otherwise, you will miss many things. Neurological patients suffer not because it is a waste paper basket subject. It is because it's a vast subject. It needs a spiritual understanding of medicine. And then only you try to study it. And once you know the alphabet, it is also easy.
Yes, ma'am.
Otherwise, you will end up investigating the wrong sites. You see? So whether it is a root, whether it is a crossing spinothalamic, or is it a posterior column. So those are the three different things you have to differentiate. If it is due to a root, acute transverse myelitis, in the uppermost level, there can be root involvement. So it will produce a root pain.
Yes, ma'am.
So patient will have episodes of sudden shock-like pain at the level of involvement. Second, it will be very small. Whatever the root, if it is a D10 root, only that segment. So that will be very clearly demarcated area. So presence of root pains and very clear demarcation to radicular territory indicates it is root. Whereas ill-defined, vague, broad, as if that is called as band, as if you have tied a towel around your trunk. So very vague upper level. There is no shock-like pain. It is as if some tight band is put over several segments in the trunk. That is classically posterior column. And additionally, if the patient gives you Lhermitte sign, lightning pains, all those things, if the patient gives history, it is all the more wonderful. Next, you said crossing spinothalamic. Very good. So if we thought about a mecentric angina and vasculitis, demyelinating disorders prefer the myelin-rich fibers, whereas vasculitic process affects the less myelinated vascular fibers. So vasculitic diseases have a tendency to involve the autonomic fibers and the pain and temperature fibers. So if supposing we have a pseudo-syringomyelic presentation of a acute vasculitis, spinal vasculitis, you call it a pseudo-syringomyelic presentation. Classical syringomyelia will not come over few days. It comes over a long period. Whereas pseudo-syringomyelic presentation of a spinal cord disease is typically described. It is described in vascular compromise happening in compressive myelopathy.
Yes, ma'am.
Yes, as well as vasculitis. So this will be again suspended, but it will be dissociated. So it will not be a band, it will not have root pains, it will have a tract pain, that is a diffuse burning paresthesia in those areas. It will not have the shock-like pain of radicular involvement. It will not have Lhermitte sign. It will be a burning paresthesia in that segment. And when you examine, you will find that pain and temperature is more affected. So that if this person had a mecentric vasculitis and a spinal vasculitis resulting in a pseudo-syringomyelic myelopathy, so that will be the thing. So this person had a band-like sensation which was not having a shooting character. It was not burning. And you typically said it was like a tight band put around his trunk. So it looks like a posterior column probably got involved. And he had a definite level. So that means not only posterior column, other sensory tracts were also involved. And he has a complete paralysis. So it is all the tracts are paralyzed in that below the pathology. That is what it apparently appears, because even at 15th day, he is still in the same state, means it is probably due to the disease itself and not due to the shock. Second, you said that he had retention of urine at the time of admission. So it is all the tracts in the spinal cord seems to be involved in this case. Second, it is definitely spinal cord. Second, you told retention. So that means you have catheterized him. So now you have no way of analyzing his bladder. So it is probably he was just into the recovery of the sphincters. So that is the stage the patients come with retention. Usually they come at that stage only to the hospital. So he was catheterized. Otherwise, you are expecting an automatic bladder in this patient. If this patient has not been catheterized, the type of bladder you expect is automatic bladder. Because the bladder cannot ask hemisphere's permission to store more urine. So once the bladder capacity is exceeded, bladder wall capacity is 300 to 400 ml. So once that ml is exceeded, the information will be sent to the hemispheres to know whether the bladder can be emptied, but it doesn't go up. So if it goes up, it will say, okay, you are in a classroom, so you have to store 1 liter, 2 liter. So it will, cortical centers will prevent the sphincters from opening. But here it is not there, only the sacral center is there. So it tries to send the information, it doesn't go. So automatically it starts emptying. That is why it's called automatic bladder. So bladder sensation or fullness may or may not be appreciated depending on the completeness of the pathology. Then automatically once 300 to 400 ml of urine is reached, it will start emptying. And it empties good amount of urine, not a dribbling bladder. It will empty some 300 to 350 ml. And at the end of emptying, there will be residual urine because of bladder and sphincter dyssynergia, which happens in all neurogenic bladder. So post-voiding, he may feel like some urine is still there and he may dribble. That is the bladder we are expecting, but it is not there. It is not a painful retention anyway. So if it is due to an element syndrome, a painful retention, but he just had a distension and you told that distension of the abdomen, not distress. He didn't have distress, he just felt distension. So with a transverse level, band-like sensation, complete paralysis with bladder involvement, this is definitely spinal cord. And in the spinal cord at the bedside, we categorize them into partial cord syndromes, complete cord syndromes, and tractopathies. Partial cord syndrome is anterior cord syndrome. That means posterior column is paired, only the rest is involved. That is definitely anterior spinal artery syndrome. Supposing only posterior column, rest is paired, then it may be a posterior spinal artery syndrome, which is less common. Or it may be hemicord syndrome, brown sick cord syndrome.
Brown sick cord. Yes.
So when only half of the spinal cord generally happens in, yes, injuries, gunshot injuries, or any other assault, hemicord syndrome. So partial cord syndromes may be anterior cord, posterior cord, hemicord, or central cord. So they are partial cord syndromes. Each one will give us a diagnostic clue. But this is not a partial cord syndrome. This is a pan cord syndrome. So at the end of the history, patient had a preceding diarrheal illness and he has no other cause, no Guillain-Barre, no polio, no cerebral paraplegia, but spinal cord. And in the spinal cord, it is a pan cord syndrome. Because all the structures, motor, sensory, everything is involved at one level. So it's a pan cord syndrome. Whereas what is a tractopathy? Supposing you take tropical spastic paraplegia. Only the corticospinal tract and mild degree of posterior column will be involved. Subacute combined degeneration. That also involved. So laterism, only corticospinal. So like the tractopathy means they are tract specific disorders. So spinal cord disorder may be pan cord, partial cord, or tractopathy. So our patient seems to have a pan cord syndrome. This was preceded by an infection and there was a gap. So if it happens along with the infection, it may be a necrotizing infective myelitis. Patient had a GIT infection, he went into sepsis and the infections got lodged somewhere in the spinal cord. So along with the infection, it can be a necrotizing infective myelitis. But in our patient, there was a gap. That gap indicates there was an immunological dysregulation took place due to any of the mechanisms which we discussed before. So it's probably a post-infectious demyelination due to GIT infection. So our patient has got a acute spinal cord syndrome. The spinal cord syndrome is a pan cord syndrome. And the pan cord syndrome is not an infective necrotizing myelitis, but it is post-infectious demyelination, most probably because of the gap involved between the infection and the development of the neurological deficit. So now you go to examine the patient.
Yes, ma'am.
So that is your history diagnosis.
Yes, ma'am. Coming to the general examination, the patient was examined in a well-lit room in supine position with an IV line in his right hand and a urinary catheter in place with due consent. The patient was conscious, cooperative, and well-oriented to time, place, and person. His vitals were afebrile to touch, the pulse 74 beats per minute in right radial artery, rhythm and volume were normal, adequate force and tension, no radioradial or radiofemoral delay, no apex pulse deficit, all peripheral pulses well felt. The respiratory rate was 16 breaths per minute and the pattern was abdominothoracic. The blood pressure was 126/76 millimeters of mercury taken in the supine position in the right brachial artery. The JVP was normal, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema, no neurocutaneous markers, stigmata of TB or atherosclerosis. The back examination showed no kyphoscoliosis or any spinal deformity. Skin over the back was normal, no gibbous or epidural swelling. Ma'am, may I
Do you
proceed?
have any bed sores?
No bed sores, ma'am.
Because why? Because if you want to think that he is still a weak grade 0 power, not due to primary pan-cord syndrome, but due to prolonged spinal shock. Conditions which prolong the spinal shock, one is the bed sore, second is sepsis, UTI, all these things. So nothing is there. Okay, then.
Yes, ma'am. Coming to CNS examination, the higher mental functions, the patient was conscious, cooperative, well-oriented to time, place, and person. His memory was intact and speech was normal. Ma'am, all the cranial nerve examination was normal. So should I read out all of them?
No need.
Yes, ma'am. Coming to the motor system, there was no wasting of muscles noted. The tone was normal in the upper limbs, but there was hypertonia and clasp knife type of spasticity in the lower limbs.
So what does that indicate? He has gone to the phase of recovery. So
Yes,
spinal shock will be phase of atony, phase of heightened activity like mass reflex, then excessive sweating above the site of pathology, and then they go into hypertonia, spasticity. That is the phase of recovery. Okay. So he is not in the shock.
No, ma'am. Ma'am, coming to power, the power was 5/5 for all the movements in the across all the joints in the upper limb, but in the lower limb it was 0/5 for all movements at all the hip joint, the knee joint, and the ankle joint.
Okay.
The coordination was normal in the upper limbs as tested by the finger to nose test and the finger to finger test. However, in lower limbs, it could not be assessed due to 0/5 power.
Okay.
Reflexes, the superficial reflexes, conjunctival, corneal, and jaw jerk was present. Abdominal was present bilaterally at the T8 level, but absent at T10 and T12 levels. Cremasteric reflex was lost bilaterally. On asking the patient to raise the trunk in supine position, there was upward deviation of umbilicus seen. The plantars were extensors.
Yes.
The deep reflexes were normal 2+ in the upper limb, but in the lower limb, there was hyperreflexia seen at the knee joint, that is a reflex of 3+, and at the ankle joint, clonus was present, that is a reflex of 4+. Ma'am, may I proceed?
Yes.
Coming to the sensory system, the superficial touch, pain, temperature, vibration, and position sense are lost below the umbilical level. A zone of hyperesthesia was present uniformly at the umbilical level. The cortical sensations could not be performed as the primary modality of sensation was lost below the umbilicus. Also, parietal lobe dysfunction was not suspected in this case. The abnormal movements such as flexor spasms were not present. Any signs of meningeal irritation were not present. Coming to other systems, in CVS, S1 and S2 were heard normally. There were no abnormal sounds or murmurs. In RS, air entry was bilaterally equal, no crepitations heard. In GI examination, there was no organomegaly and it was a soft per abdomen examination.
Okay.
Ma'am,
So
at
the end of the examination, now tell me the structures involved. After examination, what all structures are involved?
Ma'am, so in this case, 35-year-old male patient is an acute paraplegia with motor, sensory, and bladder involvement, involving the corticospinal tract, the dorsal column, the spinothalamic tract, and bladder innervation, with lesion most likely at the level of spinal cord at the T10 segment. The most probable etiology being acute post-infective transverse myelitis, causing non-compressive myelopathy without any complications such as COTY, DVT, pulmonary embolism, or bed sores.
Wonderful. So after examination, you have got only one additional point. It is still a pan-cord syndrome, but it is no more in the phase of shock. It is in the phase of recovery. Patient's hypertonia has come. In the phase of shock, it is atonia, heightened activity, then it is recovery. So now the patient is going into spasticity, which is due to the disconnection of the corticospinal tract rather than, so that means whatever functions which can be carried out by the corticospinal tract at the spinal level independently is producing the spasticity. It is a protective thing. It will help the patient to stand even when the power is grade 0 over a period of time. So it's a protective mechanism. So what you have is a complete Pankot syndrome involving all the tracts. So at this point, I will want to tell some small things. All of you know that. So in your exams, people will ask what is the way you connect the difference between, this is not a compressive myelopathy. It's a acute non-compressive myelopathy, which doesn't become a differential diagnosis for compression also, because compressions go on over a period of time. So it becomes a differential diagnosis only when there is a long-term non-compressive myelopathies like HIV myelitis or subacute combined degeneration, tropical spastic paralysis, not this condition. So that question doesn't arise. But people will ask you, how are you going to differentiate the relationship between the vertebra and the segments? So spinal cord case for undergraduate students always ask that question. Would you like to tell?
Yes, ma'am. Ma'am, in the cervical level, because we have C7 vertebra and C8 spinal nerves, so it is like till 7, it is the same. At 8, it goes 1 below. In the thoracic segment, we add 1. In the thoracic level, we add 2 for 1 to 6. Then 7, 8, 9, we add 3. Then T10 comes at L1. And then the spinal cord finally ends at L1, it ends, and then the roots go down. That is the chorda equina.
Very good. Excellent. Next, you should be telling what are all the various ascending tracts and the descending tracts in the spinal cord. These are common questions. So would you like to answer them?
Yes, ma'am. The ascending tracts are the spinothalamic tract and the posterior column, that is the dorsal column medial lemniscus system. And the descending tracts are the corticonuclear tracts and the corticospinal tracts. Then in corticospinal, there are pyramidal tracts and extrapyramidal tracts. The extrapyramidal tracts are rubrospinal and tectospinal. All of them come in extrapyramidal tracts. Okay,
but in the ascending tracts, you should also mention the spinothalamic.
Yes,
then the spinocerebellar tracts.
Spinocerebellar,
yes. Column. So spinothalamic, spinocerebellar. Then you have got spino-olivary, spino-reticular, spinotectal. From the, just remember, spinal cord to the medulla, you have got spino-medullary, spino-olivary. Spinal cord to the pons, you have got spino-reticular. Spinal cord to the midbrain, spinotectal. Spinal cord to the structures above the midbrain, spinothalamic. Then spinal cord to the cerebellum, that is spinocerebellar. So ascending tracts apart from posterior column, you have got spinothalamic, spino-olivary, spino-reticular, spinotectal, spinocerebellar. Descending, you have got classically the corticospinal tract and the cerebrally originating extrapyramidal system, as you rightly said. Then, of course, if you want to mention them, you can call them as rubrospinal, reticulospinal, olivospinal. These are the various descending tracts. So that is good. So now how we are going to investigate this person and what you are going to postulate, what are all the possibilities. It is correct, it's a Pankot syndrome. So what are all the situations Pankot syndromes happen? One is acute post-viral demyelination. Second, it can be an autoimmunity where infection just played a role, but primary disease is not autoimmune, like you have got not triggered by infection. Primarily not triggered by infection, but infection can trigger any immune-mediated syndromes. So whether it comes under spino-optic MS, or is it coming under NMO spectrum disorders? No? Or so these are, or is it a spinal vasculitis? So these conditions you should keep in your mind. So how are you going to differentiate and say that this is only a post-viral Pankot syndrome? Generally, as you know, NMO spectrum disorders have got
antibodies.
Yes, antibodies may be there. And radiologically, it will involve several consecutive long segment spinal cord with at least subclinical optic nerve involvement may be demonstrable. And a patient might have vague non-specific symptoms like vomiting because of the periaqueductal gray. So you will think that the vomiting is due to gastroenteritis, whereas diarrhea would have stopped and still patient might have been vomiting. Then you think that it is gastritis due to the drug. So if you do the MRI, we might find a periaqueductal lesion. So signs of periaqueductal involvement like persistent vomiting, subclinical at least optic nerve involvement, and multi-segment spinal cord involvement, that is favoring NMO, whereas spino-optic MS, that is an Asian form of MS. He is belonging to that age group only, but spino-optic MS is a patchy cord syndrome. It does not produce a pan cord syndrome. It picks up small tracts to start with, very over long time when there is, in case it becomes a primary progressive MS where all tracts are consecutively recruited, all pan cord syndromes might come. But typically spino-optic MS is a patchy cord syndrome. So patient will be not this much disabled in the first setup itself. Small lesions, discrete, will be scattered. That is multiple sclerosis. Then are we considering a vasculitis conditions like you have got systemic vasculitis or arteriovenous malformation sometimes can present with acute presentation due to steel or bleed. No? So vasculitis will show the vascular pattern, anterior cord, posterior cord or central cord pattern, or if it is due to some hematoma, some febrile thrombocytopenias and hematomas, you may have a cord hematoma, which is an extremely painful condition. We are not thinking like that. So we can do the imaging, and depending on the radiological appearance, if it is respecting an NMO, there is a risk of recurrence. So what is the pattern? It is definitely not a spino-optic MS because it is not a patchy cord syndrome. So it is either an acute post-viral demyelination or an infection trigger NMO spectrum disorder. Those become the differential diagnosis. So what investigations you have done? Because if it is acute transverse myelitis, it is only a monophasic illness, you are going to treat only once. Whereas if it is belonging to the NMO spectrum, then you may have to continue the treatment for a longer time. So that is the relevance. So that is why you should do the NMO antibody, whether you are to treat the patient for 2 to 3 years or not. No. So what is the MRI showing?
Ma'am, MRI, I don't have the investigations of this patient.
Okay. So let us imagine it is not NMO. At this point of time, how are we going to treat him?
Ma'am, if it
doesn't look like an infective, doesn't look like an infective. You know that Epstein-Barre virus. Necrotizing myelitis can happen with Epstein-Barre virus. Or sometimes it can happen with the varicella virus. So if it belongs to viral etiology and it is having a treatable virus etiology, then we will treat them. If it is a varicella and producing necrotizing myelitis, you may have herpes. You see, you have a segmental herpes and this goes into the cord. In that situation also, you can give acyclovir. Epstein-Barre virus, of course, you don't have any treatment. So specific organism related treatment, if it is possible, we will give. If not possible, you are not going to give. Then you have a cord edema. So cord edema is treated with high dose methylprednisolone. Then you have taking care, you are caring for the back, bowel and bladder.
Yes,
already patient has gone into the phase of recovery. So you have to wait to keep the muscles of his limbs alive, prevent contractures, prevent bed sore, prevent urinary infection, so that whatever parts are capable of recovering due to partial injury will recover. So physiotherapy plays a very important role. And after that, in this kind of patients, when they become spastic, One thing you should remember, he's having grade 0 power. You said he grade 0 power, but he's spastic. Never try to give antispasticity medication, because in this patient, spasticity is protective. On the other hand, if the power is grade 5 or 4, but patient is unable to walk due to severe spasticity, that situation we will give antispasticity agent. Their spasticity is the culprit. Whereas here is your patient, it's a very important point. His power is grade 0, but is spastic. You may be able to help him. So because of the spasticity, over a period of time, his legs might become like a pillar. So he can walk on the pillar. Maybe there is something called treadmill training. Normally when there is they will drag, both legs are spastic. So they will drag their legs, and because of the spasticity. But there is a treadmill training where the patients are suspended from above and the legs are fixed on the treadmill. So when the treadmill moves, the flexion movements also comes. So patient slowly learns to flex the knee. So spasticity will be protection for this patient. So this patient's spasticity should not be treated. You found spasticity, but we should not treat it. You told me you found spasticity. So yes, spasticity with grade 0 power, spasticity should be utilized to help the patient to walk. So even if the treadmill training is not helping, there is something called robotic walking. Patients' limbs, if they are stiff, they can be fitted into robotic legs, and they can move by external operation. But if the leg is flaccid, you cannot fit them into robotic legs. So this spasticity should be exploited to help the patient. But still the patient's only 15 days. They continue to recover for 1 to 2 years. So we should not lose hope. Continue to do all the other investigations. If none of them is coming up, we'll continue to keep the limbs alive, prevent contracture, prevent infection. Do not treat spasticity. Instead, utilize spasticity for rehabilitation. You presented very well. For an undergraduate student, you are excellent. So great. Neurology is a very beautiful subject, but many times the tragedy is neurologists themselves will be in a very busy state. They may not spend enough time, because neurology, you can never boast that I made a diagnosis in 5 minutes, 10 minutes. It takes time, and the time will be rewarding, because it is somebody else's life, their valuable possession. So good, very good, excellent presentation. So any questions you can ask me.
Ma'am, I have some doubts, like very undergraduate level doubts for your level. So, ma'am, the difference between, can you please explain the difference between rigidity and spasticity? We have read this right from our first year in physiology, but still I get confused every time, no matter from how many books I've read this difference table, because it comes in exams.
Rigidity and spasticity are both belonging to hypertonia. And rigidity is a uniform hypertonia involving agonist and antagonist and present throughout the range of movement. So rigidity is increased tone, which is present both in the agonist and the antagonist, and it is present throughout the range of movement. Whereas spasticity is, and it is not dependent on length or velocity. Rigidity is not dependent on length or velocity. Whereas spasticity is velocity dependent increase in resistance to passive stress. As you increase the velocity, spasticity becomes more obvious, and it involves the agonist more than the antagonist. So spasticity is velocity dependent increase in resistance to passive stress, involves one group more than the other group. Whereas rigidity is uniform hypertonia involving agonist, antagonist, and synergist. It is neither velocity dependent nor length dependent. That is the difference. Clear, huh?
Yes, ma'am. I have one more question.
Yes.
Ma'am, in GBS, I've read that objective sensory loss is not a classic feature of GBS. The sensory loss, if present, is only subjective in the form of tingling. So, ma'am, what is the difference between objective and subjective, and why GBS does not have objective sensory loss? Like the antibodies can also affect the sensory nerves, no?
GBS produces objective sensory loss. You see, only thing, it does not involve the small myelinated fibers. So pain and temperature may not be involved.
Okay.
Proprioception will be involved to varying degrees. So it's a well myelinated fiber. Proprioceptive fiber is a well myelinated fiber. It involves that. So if you are not getting a typical tingling, if you are getting, that means that proprioceptive fiber is involved. Irritative symptom will be followed by destructive symptom. You should do dynamic joint sense, timed vibration. If routine joint sense is not picking it up, or if the routine tuning fork is just appreciated, you do the timed vibration. Definitely it will be involved. Almost all the cases it is involved, but it is not the disturbing symptom. Disturbing sensory symptoms are pain, severe pain, and they may have tingling. Pain itself is sensation only. That's an irritative symptom. And definitely, if you examine carefully, dynamic joint sets at least will be involved. 1 degree movement is dynamic joint sets. Timed vibration in a young man, he should appreciate vibration for at least 15 seconds in the angle and 20 seconds in the anterior superior iliac spine. That will not be there. So, movement, it will be significantly involved. If you feel that my patient is not having, that is because you are not looked for the fine proprioceptive impairment. Pain and temperature will not be involved because it's a small fiber. Unlike the atypical type of AADPs, pain and temperature is not involved because it is not a well myelinated fiber.
Thank you, ma'am.
Wonderful. God bless you. Become a neurologist and save neurologically ill patients.
Ma'am, you are the only inspiration, ma'am. Like having listened to so many of your videos, watched so many of your videos, you are the inspiration.
Thank God. Krishnarpanam, we'll do Krishnarpanam. God bless you. Thank you very much. Okay. Shall we close?
Ma'am, I'll just check if there are any doubts on YouTube.
Okay, okay.
Yes. Ma'am, the way you explain topics is so very helpful. Like the analogy and the examples that you used to explain in one video, you had explained this spinal cord cerebral system, that in the form of like, if this is if the main person is not there and then you leave the work to the spinal cord, then it will get disturbed. And so all those examples help us remember things even better. Ma'am, just ma'am, there's one doubt over here. Why is they are asking that would the jaw jerk was present in this case, so wouldn't that indicate UMN lesion?
Jaw jerk, patient has an UMN lesion, clearly. Exaggerated reflexes, hypertonia, upgoing plantar. Jaw jerk only points the level, but it is not exaggerated in your patient. It's a normal jaw jerk. No? Does he have an exaggerated jaw jerk?
No, ma'am, it was a normal jaw jerk.
Normal jaw jerk will not be affected if the lesion is at the level of D10 with the beaver sign and all those things.
Yes, ma'am.
So jaw jerk affects if there is a disseminated lesion and brainstem lesions are there. So normal jaw jerk is normal only. Any other?
No, ma'am, that was the only doubt there.
Okay, thank you. Thank you. We will meet when you find another case to discuss. Okay.
Sure, ma'am. Thank you so much for taking out time from your busy schedule and doing a case discussion with an undergraduate. Like, you are a legend in neurology. So in front of you, we all are kindergarten students.
No. You are the future of our country and our patients. No, future is in your hands. Every job is very, very important, as you know. And if future students are not taught properly, means that's the best way to destroy a nation. If future student doctors are not trained well, you don't treat well. engineers are not at well, they damage buildings, all those things are there. So it is the smallest thing I can do to my country. So and if
Thank you so much, ma'am.
take
We
care
need teachers like, we need mentors like you so much. Ma'am, actually, in this case presentation, I would like to thank my medicine professor from my college. She helped me throughout this case, and it was only because of her guidance that I could actually comprehend that what is going on in the patient. And after listening to your discussion today, I mean, I got a new dimension to look at neurology, because without even mentioning what tracts are involved, just looking at the symptoms, you made a diagnosis of a pan-cord syndrome here, and we, even after taking the whole case, we are lost that what is going on exactly. So ma'am, it's an honor to get to listen to legends like you. Thank you so much, ma'am. I just don't have enough words to thank you enough.
Thank you very much. God bless all of you.
Thank you, ma'am.
Thank you so much.